Alright, in this audio I will begin with intestinal obstruction. We have mechanical obstructions and we have non-mechanical obstructions. Mechanical obstructions are when the bowel is blocked by something that's outside of the intestine, such as adhesions or from Crohn's disease from the bowel wall or from a tumor. A non-mechanical obstruction is when there, or paralytic ileus, that's when there's a disturbance of the neuromuscular tissue and there's a slow in the movement of intestinal contents. So the contents of the intestine, we know that there's food, fluid, we have different types of secretions, and we can even have air. Distension results from our intestines not being able to absorb the contents and move them down the tract. Now, it's important to remember that hypovolemia as well as electrolyte imbalances can occur with intestinal obstructions. Obstructions high in the intestine, those cause loss of gastric hydrochloride, which leads to metabolic alkalosis. And then opposite, obstructions in the lower part of the tract, those cause metabolic acidosis from loss of alkaline type fluids. Now, strangulated obstruction can occur. With strangulated obstruction, that's when there's an obstruction and there's a compromise in the blood flow. The risk for peritonitis increases when the patient has strangulated obstruction. Bacteria without blood supply releases an endotoxin, and it can make the patient at risk for septic shock. Now, mechanical obstruction, typically, we talked about the adhesions, can be from a tumor. Mechanical obstructions can be from appendicitis, fecal impactions, intussusception, which is where the bowel kind of folds back onto itself. They call it telescoping of the bowel, or any type of vascular disorders. Okay. Now, postoperative ileus, or the non-mechanical obstruction that we mentioned, that's mostly caused by handling of the abdominal contents, typically with surgery. Now, it's important to monitor for intestinal ischemia because that's another cause of ileus. Now, nausea, vomiting, and the color of the patient's emesis should be noted. We want to know the onset, any aggravating factors, any alleviating factors. If there's severe pain that stops and changes to tenderness on palpation, that can indicate perforation. We can see if obstruction expected. If we see obstruction expected, we want to keep that patient in PO. Now, we want to assess for a family history of colorectal cancer. We want to make sure that we are monitoring the patient for any fever, tachycardia, hypotension, or abdominal pain or rigidity. Okay, we want to report those to the physician. Now, obstipation is when the stool cannot pass. Obstipation and failure to pass gas, those typically correlate with a complete obstruction. Diarrhea can be present in a partial obstruction. Now, with the mechanical colonic obstruction, the patient typically has a colicky abdominal pain. They can have ribbon-like stools if the obstruction is partial, or they can have obstipation and abdominal distension. Now, it's important to observe for abdominal distension. It's also important to observe for any peristaltic waves. We want to auscultate, and if we hear any high-pitched vowel sounds, we know that that's an early sign of the process of obstruction. Okay, non-mechanical obstruction, the pain is typically very constant. If you look on page 1159, chart 56.5, there is a diagram, small bowel obstructions versus large bowel obstructions. Now, there is no no laboratory test that can confirm obstruction. We might see hemoglobin, hematocrit, creatinine, and blood urea nitrogen values elevated, and that can indicate dehydration. Abdominal CT scans can be done, as well as abdominal ultrasounds. Whenever we send these patients home, we need to make sure that we are, if constipation was the cause of the obstruction, we don't want them to become constipated again, okay? A lot of times while the patients are in the hospital, we're going to see non-surgical management, such as the patient being NPO and placing an NG tube to help decompress the bowel. Okay, now whenever the patient has an NG tube in their NPO, they're most likely going to have some sort of nutrition like TPN. We are monitoring for any type of bowel sounds. We're monitoring for flatus or gas. Gas and stool means that peristalsis has returned. Now, typically we can give drugs for these patients with postoperative ileuses to increase their GI motility. But like I said, we want to make sure that we're replacing their fluid and maintaining their nutrition. Sometimes these patients will be allowed to have ice chips. It's important to note that if the pain changes from an intermittent to a constant pain, we should alert the healthcare provider, because that can mean perforation or peritonitis. Now, surgical management, we can see the exploratory laparotomy. Surgical procedures typically depend on the cause of the obstruction. Obstructions that are caused by tumors or diverticulitis typically are going to result in the individual having to have a colon resection. Now, if anastomosis is not able to be met, then the colostomy comes into play, and it may be temporary or it may be permanent. Now, we have minimally invasive surgery, and then we have conventional surgeries. Okay, conventional surgeries are what we call open approaches, and that's where there's a very large incision. Minimally invasive surgeries are when we have small incisions and cameras and endoscopes or laparoscopes are placed into the abdominal cavity. Now, remember that the NG tube needs to stay in place until peristalsis is returned. When we are deciding on the functioning of the bowel tract, we may hear some bowel sounds. We can report that to the physician, and they might want us to clamp the NG tube. Whenever we clamp the NG tube, they'll tell us to clamp it for, 30 minutes or so many hours. And if the patient doesn't have any nausea or vomiting, then typically the NG tube is removed. But while the NG tube is clamped, if the patient does experience nausea or vomiting, the NG tube is hooked back up to suction. Okay. Now, with abdominal trauma, we can have blunt abdominal trauma and we can have penetrating abdominal trauma. With blunt abdominal trauma, the spleen is typically the most common injured organ, and with penetrating abdominal trauma, the liver is the most common damaged organ. Now, we want to make sure we're inspecting the abdomen of any patient with an abdominal trauma. We want to look for any bruising that can indicate internal bleeding. We want to auscultate the abdomen for our bowel sounds. Okay. If we're not sure the patient has bleeding, then they can undergo a diagnostic peritoneal lavage, or DPL, and that's when a catheter is inserted into the abdomen and fluid is inserted into the cavity, and then the drainage that comes out from the abdomen, if it's pink or bloody, then they typically prep the patient for surgery. Now, it's important to remember to maintain the ABCs for these patients: airway, breathing, circulation. Now, 2 large bore IVs should be inserted, and the patient's laboratory values such as ABGs, CBCs, coag studies, and liver function tests should be monitored. With most abdominal disorders, we are going to see NG tubes placed. Now, NG tubes can help to identify bleeding and to decompress the stomach, but we never want to use an NG tube on an individual that has a skull fracture. Okay, we want to make sure that the patient that comes to us that has had abdominal trauma, that we're monitoring this patient every 15 to 30 minutes. Now, intra-abdominal pressure is typically measured in or monitored in these patients. In a healthy adult, it's 0 to 5 millimeters of mercury. Whenever we see that intra-abdominal pressure at 12 millimeters of mercury or higher, that's considered intra-abdominal hypertension. If we see it at 20 millimeters of mercury or higher, that's considered abdominal acute compartment syndrome. Okay. Now, whenever intra-abdominal pressure becomes increased, the patient is at risk for DVTs and PEs due to impaired venous return, because the higher that pressure comes in the intra-abdominal area, then the central venous pressure, the inferior cava, can become compressed. Now, it's important to monitor for signs of peritoneal irritation, such as rebound tenderness, significant blood loss, evisceration, or monitoring with a gunshot wound with possible peritoneal involvement. Okay, signs and symptoms of abdominal bleeding are abdominal pain, nausea, vomiting, black stools, fever, weakness, and dizziness. Okay, if you guys will read over polyps on page 1163 and malabsorption syndrome on 1165, that will conclude chapter 56.